Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Hello, everybody, and welcome. I am so delighted. I couldn't be more happy to have Dr. Shereen Lim here with me today. How are you doing, Dr. Lim?
Yeah, we are very well, Nicole. And, you've really accommodated me at very last minute after there was some mix up with the time. So thank you so much for doing this.
Well, the great thing about being in this digital world of Zoom and all these visual podcasts and way to connect with people is that I can be talking to you. You're in a different country. You're in Australia. It is tomorrow. So it is a Monday for me, a Tuesday for you. It's afternoon for me, first thing in the morning for you. It's just so amazing how, we can connect this way. And I appreciate you for being with me so early in the morning, your time. So really the appreciation goes to you. I'm going to do an introduction for Dr. Lim, and I just have a lot of good questions and conversational topics. I wanted to speak to you for a really long time about the book you wrote and just to connect with you. I follow you on social media on Facebook, Dr. Shereen Lim. I urge everybody to follow you on Facebook. I don't know how you read so many articles, but Dr. Shereen posts almost daily, definitely weekly, amazing summaries of articles, amazing photos of, red flags, things we should look for in our patients, in our children, and really the most up-to-date information. I learn so much from you and reading your social media posts. So I really thank you for all that you do and being up to date on all the research and the information. So thank you, Dr. Lim.
No, thank you. I'm really excited to speak to you. We haven't actually spoken at depth, and I love your work and hearing you speak. You bring so much expertise in very short amounts of time during your talk, so I really respect your expertise as well.
Thank you. Yeah, we get to chat quickly at conferences and things like that. So if you don't know who Dr. Shereen Lim is, which you probably already do, she is a Perth-based dentist with a postgraduate diploma in dental sleep medicine from the University of Western Australia. She has been involved in the team management of snoring and obstructive sleep apnea since 2011. Dr. Lim is dedicated to promoting airway health from infancy as an alternative approach to minimize the development of these problems. And she is the author of the book, Breathe, Sleep, Thrive. Discover how airway health can unlock your child's greater health, learning, and potential. I have the book right here. I think I have 2 copies of my own, and then I bought, I think it was 25 copies for my office. And it went to every new pediatric patient, the parent of every patient, after I bought those books for every the parents just need to read this. It's information that's great for adults, but a lot of it's geared towards the child and how the parent can help manage and identify such issues. Dr. Shereen Lim works in a private practice, which is restricted to tongue-tie management from infancy to adulthood, early interceptive orthodontics, and myofunctional therapy. So I was on your website, and what I do is I have people send me a bio, but then I also do all this research about them, and I just find so many things fascinating. And on your bio on your website, you state that you're a dentist with special interest in helping children overcome challenges with infant feeding, swallowing, breathing, chewing, and speech. I do this through a collaborative team approach to tongue-tie management and promoting good oral function and good jaw development. When oral function and jaw development is off track in childhood, it affects the way our airway develops and works and the way we breathe, sleep, and grow. Getting to the root of poor oral function and jaw development when there are functional problems ultimately promotes better airway health, breathing, and sleep, which in turn unlocks greater health and wellness for life. Most of what I do today was not taught to me in dental school, and it came from my learning from many different perspectives and world-leading experts in their field. And what I just love about this, Dr. Lim, is your holistic approach and your understanding to the growth and development of the human face. You're not just thinking about teeth, but you get function and how breathing and movements and chewing and swallowing impact the way the face grows. So thank you so much again for being here.
Thank you.
Let's talk. I want to talk about how you got interested in dentistry, kind of stepping back to like the roots of how you got started. Why did you want to become a dentist? But then how did you get interested in Airway? Because as we just said from your website, it's not all this information wasn't taught to you initially. So where did you get that maybe aha moment, or what happened for you?
Yeah, so I'm not one of those people that said I need to be a dentist from very young. It was in my final year of high school, getting that list of top potential jobs that I could do that matched my subjects and my marks. And I had a couple of choices in terms of physiotherapy and dentistry. And the fact that you needed to get a bronze certificate in swimming for physio, and you had to disrobe during your practical sessions, made dentistry a very easy choice for me. I actually did love going to the dentist when I was young. I had a good experience, but I didn't understand the full scope of dentistry. So yeah, it's a job that I went into, and I think it's the perfect expression of art and science. But then when I became involved in Airway, it was really prompted by my husband snoring. It was driving me pretty crazy, and I got up and I thought, you know what, I'm going to learn about these dental sleep appliances, because I was vaguely aware that they could help people with snoring. And I decided I'm going to learn more about this because I want to help other spouses. This is super frustrating. And I enrolled in Australia's first postgraduate diploma in dental sleep medicine. And so that's how I learned about that, and becoming involved, accepting referrals for people that needed these dental appliances. I started to question, if we're dealing with poor jaw anatomy, how come we aren't growing jaws properly in the first place? A lot of these people are suffering. It's quite despairing to listen to people that aren't getting good quality sleep. And so I wanted to know, how come we don't grow jaws? We're taught in dental school, you can do early interceptive orthodontics at age 7 to 8 years. I'd come across Dr. Christian 𝐃𝐈𝐒𝐂𝐋𝐀 work. He was doing palate expansion. It was helping children breathe and sleep better. And speaking to orthodontists, they said, no, we don't believe this. And my own children were quite young at the time, and I wanted to be able to offer them early interceptive orthodontics. So I thought, well, I'll have to learn this. So that got me further and further down the rabbit hole. And then meeting Dr. Christian 𝐃𝐈𝐒𝐂𝐋𝐀, 2014, I said, your work has inspired me to learn orthodontics. And he said, if you're doing orthodontics, it's too late. So at that time, I had no idea what he was saying, but I understand form follows function. And if the jaws grow the most in the first 6 years of life, we need to pay attention to that poor form or poor oral dysfunction that actually leads to poor jaw development. And so that's how I learned about tongue tie and myofunctional therapy and promoting nasal breathing. So yeah.
What an amazing experience to first start out with your husband, and you're like, okay, I'm just going to help him because it's bothering me. And then to really continue to look deeper and to research, take courses, and then, learn to such a depth that you're now in the preventative aspect of it.
Mm-hmm.
Were you always working with the pediatric population, or when you were helping your husband, were you working with adults at the time?
Yeah, mainly adults and, children for very general dental cleaning and that. I didn't have a lot of confidence with children. In fact, we had the type of practice where people would come in, be really happy. They want to bring in their children, and nobody wanted to see the children. So it was just very cringy for the front office team to deal with. So getting comfortable with children has actually been required because of what I do. It wasn't something that I really worked with before. But now, yes, I'm really happy to work with children.
In your practice now, is it both pediatrics and adults, or is it only pediatrics?
I mean, personally, what I see is largely children and infants. But yes, I will see adults for tongue tie release. And so even though I'm now, really well qualified to offer the dental sleep appliances, it's not something that I do. I think there's many other dentists that can now do this, and my preference is to stick with the children.
So you really shifted from the adults to the children, which can be very scary. Like you said, if you're not trained in working with children, getting in their mouths, getting them comfortable with you doing that it's challenging for all fields. Even as a speech therapist, if you're not used to working with young children, under the age of 4. It's a lot different than working with an 8, 9, 10-year-old or and above. How did you become comfortable working with little ones? And I see on your website, you are like such a mom with all these little babies and doing tongue-tie releases. You have a lot of little babies that you're holding, and it just seems so natural for you. How did you shift to feel that comfort in treating children?
Yeah, well, digital scanning made a very big difference. So then, it became quite simple to see 7 to 8-year-olds, but going down to 4-year-olds is a bigger jump. And around that time when I started, doing expansion 3.5-year-olds was around the COVID time. We had a very good oral health therapist who was just amazing with children. And she saw a lot of the children for general dentistry, and just watching her, how she engaged with children, how to get them to open up and just make them feel special. That really helped me. She said, just ask them questions. If they don't answer, keep asking again, really getting down to their level. And so it was her that really helped influence me, and even the whole team, to how we administer, anesthetic, how the team can actually be trained to look after that child so that they're very distracted and they don't know what we're doing. So yeah, she was very instrumental in it.
I think that's probably true for a lot of people. A lot of people have like a natural gift to work with children, but to be mentored and shadow someone, I feel like it's really important. I worked in a preschool program for a few years, and I had a mentor. She was there for like 20 years or something. And I just did my internship with her, and I just copied what she did. And you just have to be so positive and, compliment children. I like your shirt and, all that energy. And I just kind of followed what she did. And I think it's a really good way to become comfortable working with younger children is to just watch somebody else who has that skill and just kind of imitate what they're doing. Because I know there's maybe a lot of orthodontists who don't treat young children because they're not comfortable working with that age. And then obviously it's a step further to actually have to go in their mouths and, do that. So I feel like that's good advice, is watching and shadowing someone else. So now the tongue tie aspect of it, because that is a big specialty area for you. How did you specifically become interested in doing tongue tie releases and lip tie releases, things like that?
Yeah, well, I understood that breastfeeding, it was really important for good jaw and airway development. And some of the common reasons for early cessation of breastfeeding is poor supply, or the perception of poor supply, and pain. And tongue tie was an underlooked issue with that as well. So that was one thing. And then hearing Dr. Herman Ramirez around 2014, the same conference that I met Dr. Christian Guilleminault, he was saying the number one modifiable factor that can influence mandibular development is breastfeeding. And so putting those two together made me think, okay, I want to be involved with helping support breastfeeding. And then following that, I listened to Dr. Kevin Boyd, who was sort of explaining breastfeeding as nature's palate expander, which really reinforced my decision that I wanted to learn how to become involved in tongue tie management. Around 2015, I think that was when Dr. Christian Guilleminault published the first paper on tongue tie and the potential link with obstructive sleep apnea. So then I started to become really interested in that aspect and learning more and more. And that's how I became involved in the area. But now it's just such a fantastic part of the practice, how life-changing it could be. It can impact so many different areas that people wouldn't think. And so, it's just a very satisfying area beyond breastfeeding.
And when I present, I also quote Dr. Ghahari, who says that sometimes the tongue tie is the first domino to fall. And if we can catch that early, because we know that develops early in utero. So when the baby's born, they're born with that restriction, which has already impacted jaw growth and maxillary growth in fetal development. I find it so fascinating. And I think I was at the same conference where you met Dr. Guilleminault. I met him as well at that same time. And it's just amazing how he did like fetal development studies and inquired about like the baby who has low tongue posture
Mm-hmm.
may be born with a high, narrow gutter palate. The
Mm-hmm.
problem has already begun in utero, and we want to get to these children early. So I love a few things you said. You said form follows function, and I think not everybody's aware of that. Can you talk a little bit about that? The form follows the function. What does that mean? Can you describe that?
Yeah, well, the way that the jaw bones grow, is actually stimulated by the muscles, the way that the muscles are working. And when it comes to the palate or the roof of the mouth, the tongue is very influential. So we need good tongue suction to the roof of the mouth during sucking, swallowing, and breathing to stimulate proper palate development. And as you said, this begins even in utero. So in terms of what else do we need to pay attention to, it's the light persistent forces that are going to make the biggest difference. So what we do at rest or the way that we breathe has a large impact on the way the muscles grow. So we want to have closed mouth, lip sealed, tongue up for good development. And in terms of the lower jaw development, we really want to have good chewing and good breastfeeding, movement of that lower jaw to stimulate the proper jaw development.
It's so true. And breastfeeding, like you talked about, is the catalyst for that, natural catalyst for that good oral development. It's almost like natural myofunctional therapy, sort of, because the way that tongue is moving, that peristaltic, so that kind of up and down pressure of the tongue can help shape the palate and helps trigger that muscle growth. But when there's a tongue tie, that's impacting mobility of the tongue. So what do you see in those infants that you work with who have a lingual restriction? What do you tend to notice, like what characteristics in the mouth, what functional characteristics, red flags are you seeing in those patients?
Yeah, I think this is where it's very difficult for people to make diagnosis or unless they're quite involved in it, because when we have a tongue tie, we can have a lot of dysfunction and no symptoms. We can do compensations, and we can compensate with various other muscles, so it play out very differently in every child. So it's not like you have a tongue tie, this is what you're going to see. Some people can have a tongue tie breastfeed without any symptoms, but they're just overusing their lips and cheeks, and that's actually altering the swallow. And they may not have any symptoms at present. Or there may be more difficulties with getting a good wide latch, and there may be problems with more pain and discomfort with feeding. Or they may have poor swallowing. So if their tongue is not lifting correctly, they may have more air, and these babies will have more reflux-like symptoms, be more prone to spit ups and vomits, and need to be held upright and be very, very uncomfortable. So there's a lot of different patterns that I see. And now we're paying more attention to body tension or the impact of the fascia in the tongue tie and how that can play out on a baby's posture as well. So I'm more in tune with that now, like picking up a baby and you can tell they're so rigid, and they've had a lot of chiropractic treatment, and the tension keeps coming back. And so you can almost predict now when you feel that stiff baby and they've had a bit of chiro treatment, doing the release can actually help release that body tension as well. So there's a lot of different things that are happened, and probably more than I've mentioned.
That's amazing. So let's talk about that more. I don't work with infants. That's not my area of expertise. But even I remember for my older son, there was a lot of tension. He had a tongue tie, but it wasn't diagnosed until he was older. But at first, I thought some of that like tension was actually a good thing because he could hold his head up, like arched back, right? I was like, oh, look how strong he is. But really, it wasn't a good thing. But there are all these signs and symptoms that I just was told is normal. But looking back now, or looking back, this was a while ago when I realized they were all symptoms of tongue tie, that tongue restriction causing him to swallow air, causing him to become very bloated, painful, reflux, projectile vomiting, arching of the back, crying a lot. He was in a lot of pain. I was still able to nurse him for 18 months because I knew nursing is going to be really good. I have to push through this. But had I known at the time, we probably could have solved a lot of issues and problems earlier because he was put on reflux medication at 1 month of age. And a lot of things that was like so much was missed. So when you're talking about that tension in the body, that's fascinating. And you experience that firsthand with these babies you see, on the daily. What is it like? So you're holding the baby, and what do you feel is different? And sometimes after the release, can you talk about how that might feel different in the body as well?
Yeah, I mean, I don't routinely pick up babies, but occasionally I'll get a cute one. I'll pick them up, and it's like you can't bend their legs; they can't sit on you, or you see their body tension, their arching, and all this. And then those are the babies you kind of have a intuition that after the release they're going to be more floppy. And yes, when I bring them back to their parents, quite often I'll notice that immediately.
Wow.
Yeah. So I've become a lot more in tune with that in the recent couple of years.
That's amazing. And I think a lot of people have, even with adults, this whole whole body connection and
Yes.
tongue being connected through the deep frontal line all the way to the toes, right? We have whole body fascial connections. And when there's tension or tightness in one area, it can impact other areas. Does it impact it the same for everybody? No, of course not. But we do have a lot of patients reporting changes in other parts of their body when they have proper care, proper pre and post release. What other types of referrals do you make for the infants that you're working with? I know you mentioned chiropractics. So who else do you have your patients, and maybe infants, but also pediatrics and other adult patients see as part of your comprehensive treatment?
Yeah. In terms of tongue tie release and doing manual therapy, yes, we refer to a lot of chiropractors. There's a craniosacral therapist in particular, and also a lot of osteopaths as well. Everyone that I see will see some sort of lactation consultant, or even an OT colleague that has some feeding expertise. I want to make sure that they've been seen by someone who can actually assess the actual feeding and work with them to introduce oral exercises and support them post-release as well. So they're the main people. Occasionally we'll have to send someone to an ENT surgeon, but they would be the main people that are involved in care for infants. And in terms of older children, adults, yeah, we still work with those chiropractors and osteos for their regular treatment and for their tongue tie as well.
Yeah. And here in the United States, there are certain physical therapists who have training. Not everybody, as you know, is aware of tongue tie, what it is, how it impacts. So it's important for patients to find the right providers who have that education. And also I see on a lot of social media posts and different groups where people might think a tongue tie release is like a means to an end procedure without really grasping that it's to help with an overall goal of range of motion, to help with oral rest posture, feeding, chewing and swallowing, that tongue placement. And so some people might just think they should get a tongue tie release and that's it, but it's surrounded by other types of therapy, like you just talked about. Patients to be prepared for before the release, have treatment after, myofunctional therapy after. If it's an infant, it might be, like you said, an OT or a speech pathologist or physical therapist, chiropractor who has specific training in helping with the whole body approach, which is really important. Do you ever get referrals or patients who might just come to you for wanting a tongue tie release and you have to talk to them about other work they might need to do to support it before you do the release?
Yeah, for sure. I mean, it could be someone referred by a speech pathologist. It's very common for children to have speech therapy for many years and really not get anywhere. And then suddenly they get a new speech pathologist who's noted tongue tie. And then you have to go into the full discussion of, okay, there is some airway issue, they need palate expansion, myofunctional therapy, tongue tie release. So yeah, it's quite common. It can be very overwhelming sometimes if people haven't really been prepped that this is the whole approach.
You're like, let's make my 30-minute visit 2 hours because I'm going to have to tell them so much. I know it's it is overwhelming when people don't understand the whole picture, but you want to explain it to them and help them understand. And it's interesting because a lot of speech therapists might not be trained in myofunctional therapy. It's not part of our initial training, that in-depth level or understanding tongue ties. So there are many children who are going to speech therapy and kind of stuck in that therapy for years without making sufficient progress because there might be an undiagnosed tongue tie or myofunctional disorder. So sometimes I know what you're saying, where you might get like that person goes to a new speech therapist, they refer them, and the parents like, why didn't anyone tell me about this? They've been in speech for years. Yeah, it's frustrating, but it's important when a child's not making progress to seek other opinions and try to figure out what's going on. What about?
Yeah, and definitely, like those are the families that have spent years knowing something's not quite right, not being able to put it together. So often when they do kind of hear it, to address the airway first, everything else can fall into place.
Exactly. It's like if we don't have the right diagnosis, it's not all going to come together. Like pieces are missing. So that diagnostic piece is so important. And a huge majority of our myofunctional patients and airway patients have tongue tie. That's one significant contributing factor. And like you talked about the Dr. 𝐃𝐈𝐒𝐂𝐋𝐀 study, I think that study, I'm presenting this week at a conference, and that's in my presentation. I think it was 450 children. Okay, I'm forgetting the percent, but a huge percent who had sleep disorder breathing had a restricted lingual frenum. And the point is, if there's a tongue tie, check for sleep breathing issues. If there's sleep breathing issues, check for tongue tie. We want to look at both because there's a high comorbidity. What about your thoughts on like lip tie and buccal ties and how those might impact function?
Yeah, I'm aware that lip tie in infants, it can restrict normal mobility, so it can restrict the depth of the latch. We can't get a good flange, and so that can contribute to their aerophagia or their intake of excess air and reflux-like symptoms. Also, sometimes if we have the tented upper lip or the short upper lip, the release can actually improve the mobility, and it can actually allow better lip seal. But recently, probably within the last half of last year, it's very rare for me to do upper lip ties in isolation. I'm always doing them with tongue tie. And so every time people tell me the body shifts and the changes that they have, I always just put it down to tongue tie. But for whatever reason, I think there was at least 3 lip ties that I did on their own. So one of them, for instance, was a colleague's, and her son actually, she wasn't sure how her son was going to cope with the tongue tie release. So she asked me if I could do one at a time just to desensitize him. And I actually did. And I didn't expect this at all, but he had reduced neck tension just from doing the upper lip tie. And so then I had another patient that was having some TMD issues. And I said, I think we should just wait till you finish the orthodontics before we do the tongue tie release. And but she really wanted to do the upper lip. She's only 16. And so I said, okay, no problems. Let's do the upper lip for her. She was more concerned about the symmetry of her smile. But when we did it, after I did the upper lip tie, she said, my shoulders just relaxed. They dropped in the chair. And that is something that people say a lot. Adults say a lot when they have the tongue tie release. But I never really associated it with just the upper lip tie. And then she said, I can open my mouth bigger. I feel free. The back of my tongue lifts better. And all these things that happened for her just because we did the upper lip tie. And so I didn't know that was possible. But then having this string of patients has just kept me really open-minded that the upper lip tie and the restriction and the impact that this has on the fascial system could be more than I ever imagined. And I need to be really open to it. And so I haven't been doing a lot of buccal tie releases. Occasionally I'll do it if I think they're really tight and it's going to affect the way that we can stretch and manage the wound for the upper lip, or maybe consider it. But now I'm reassessing. I think, I really wouldn't have understood that the upper lip tie could be so impactful when we do the release. And so if there is body tension, it probably is playing out somehow in ways that we don't know. And yeah, a lot to learn of. So I'm going to be a lot more open regarding the buccal.
Really fascinating. I'm sure we're going to hear from you, whether you're going to do a research study or put together a case series or something, or other people as well, on some changes with just lip tie or buckle. but I know the majority of cases when there's a restricted maxillary frenum, so when there's a lip tie, there's usually also a tongue tie. And if
Yes.
we're not seeing the tongue tie, it might be because the person might be missing that mid-tongue restriction or that posterior aspect. Do you feel that's correct?
Yeah, yeah. And that is why I've never really had the opportunity to do the upper lip ties in isolation.
Okay.
Yeah.
Wow. So, okay, let's talk about the difference between like genetic component and the like epigenetic. So, like the nature versus nurture and what causes the mouth and jaw to not grow correctly. Can you talk a little bit more about that?
Yeah, I think we are all born, most of us are born with the genetic potential to grow full jaws. And for instance, anthropologists who have been studying the human skulls have actually found that there has been over the last few hundred years with the industrialization and the introduction of more processed foods, that is when there was an increased prevalence of crowding. So in that short space of time, it's thought to be not a genetic change, not a change in our DNA, but it's a way, it's a change related to the way that our genes are expressed, determined by the environment and how we're using our muscles. So when we're using the more processed foods, we're actually not using our jaws as much. It's not stimulating that development. We're introducing dummies or pacifiers, which are altering muscle function. We're not breastfeeding as long. There's more formula and bottles. And so all these changes, increased pollution, living indoors, affecting the way that we breathe, they're all changing the way that our muscles are working. So it's more of an epigenetic influence rather than a DNA change.
Yeah. And so, what would you, if you could list like some red flags for sleep, breathing, and airway issues that you might see in your patients? I know you posted, you had a photo you put on social media showing like why benefits of early palatal expansion. And you had commented that you like to start at least age 5.5 or 6, well before the first adult front teeth come in, to address potential issues with dental and airway health, setting that foundation, that better foundation. In the photo, you show that there was crowding. So there was lack of spacing between baby teeth. And you also showed there was a crossbite. So the top teeth did not sit outside the lower teeth, and that could throw that jaw development off track. You showed even the child had tooth grinding, signs of tooth wear. So signs of tooth grinding. There was tooth wear. I'm going to have you talk more about that. In that picture, there was also an open bite. So the teeth didn't come together and the upper teeth didn't cross over the lower teeth, but there was a big gap between the upper and lower, and also inward tilting lower back teeth. So lower back teeth that are tipped towards the tongue, tipped lingually. You commented that might show that the upper the palate, the upper jaw is too narrow. So can you kind of go into a little more detail and other things that you might see that are red flags for poor jaw growth and airway issues in children? You also listed functional concerns. I kind of listed everything you probably want to say. It was such a good post. I'm reading it all. Well, you talked about mouth breathing, snoring. I'm actually reading what you posted because it was so good. Ear infections, bedwetting, speech difficulties, challenges with emotional regulation, attention, concentration. Anything else we might see in a child? Like if a parent is not sure if there's a problem, what should they look for?
Yeah, I mean, look, all the signs of disturbed breathing and during sleep, we want to see when a child is sleeping. A lot of parents think, oh, my child is a perfect sleeper because they weren't disturbed by their child through the whole night without really necessarily watching their child. But we do want children to be quiet and still and looking rather peaceful. So anything like mouth open breathing, we want them to breathe with their lips closed through their nose. So if there's any sound that could indicate increased resistance to breathing, any snoring, gasping, they're all red flags. Tossing, turning, drooling, sweating, bedwetting, teeth grinding, very strong red flag, or just unexplained awakenings. When the child goes into the room in the middle of the night to be with mum and dad, there could be an underlying breathing disturbance that is woken that child. And then during the daytime, are they waking at a reasonable hour, not too early, waking refreshed. They should, looking at the things like emotional regulation, attention, concentration, anxieties type symptoms. They could all be symptoms of disturbed breathing during sleep. But when it comes to children, I think when I started to get involved in wanting to do early intervention, I thought it was the jaws. The jaws were the problem. But what I think we need to promote in the future is to unlock airway health from infancy. And the earliest warning signs of problems are when the muscles aren't working correctly. So it'd be breastfeeding problems. And when we look at breastfeeding, we actually want to not adopt compensations. It's not enough to say that just because a baby is not creating pain or they're getting good weight gain or we can put them on a shield, we actually should pay attention to the way that the mouth is being used. And looking at things like, pacifiers, minimizing their use, and all those myofunctional disorders, they're really the first red flags of problems that are going to develop ahead, whether it be ear infections or difficulties with chewing, speech concerns. They're all signs that the muscles may not be working as optimally. And, we can compensate and use other muscles, but if we don't use our tongue well, ultimately that'll play out down the track, especially during sleep. When all the muscles are relaxed, we need that tongue to work well, because that tongue resting well is going to develop the jaws well. And it is really the main upper airway dilator. The genioglossus forms the bulk of the tongue. And if that's not working well, it will impact how stable our airway is during sleep. So I think recognizing for parents that the first warning signs are myofunctional disorders.
Beautifully said. And I love how you said unlock airway health from infancy. The earlier we can identify and treat dysfunction, the better the outcome will be in many cases, because such issues are progressive, right? If they're left untreated, it kind of gets that cascade of problems that occur, and the compensations are also problems. It's great the human body can compensate to survive, but then we have to unlock some of those compensations. So we really want everybody, parents, practitioners, to really have their eyes open to looking at these red flags, what you just talked about. And what would be like red flags looking at the teeth and the mouth and the face? And also, I tend to ask many questions in one question. Sorry. I'm like, sorry, but I'm also thinking one of your posts, I remember it showed a child, I think it's like a rare unicorn, but when there's like a nickel-sized space between each tooth, each baby tooth, that's what we want. And why is that? So can you talk about that?
Yeah, we want little spaces between the teeth, the baby teeth, particularly the front teeth, because the permanent teeth or the second teeth are going to be much bigger. So when we have no spacing in between the baby teeth, that's actually a severe dental crowding problem waiting to happen. But really the underlying issue is that the jaws haven't grown properly, and the jaws form the framework for our airway.
That's so amazing. And I think maybe a lot of parents don't know this, and maybe practitioners who aren't in this field yet or understand yet. And I know I didn't know this a while ago, that there should be spaces between the baby teeth because the adult teeth are a lot larger. You just think like if you see a child with like their teeth look lined up and touching, you think it looks good, but to actually think, wait a second, that's a problem, is a really interesting concept. I think a lot of people might not be aware of. What about dentists or other practitioners who aren't understanding the airway component yet? I know these things can get missed, like the crowding or narrow palates. What are other things that they might be red flags in a child in terms of facial features or oral features of airway or poor growth issues?
Yeah, features that other dentists should recognize.
Yeah.
Well, I definitely think. Pardon?
Or even parents, or like looking at a young child, what are things that we should think like that's a problem? Like I know really worn down teeth from grinding is a problem, and what other things?
Yeah, definitely. I mean, the worn teeth is really the strongest red flag. One of the strongest red flags in the mouth that a child may not be breathing well, being a stress response to actually help to keep the airway open if it's showing signs of collapse. So very protective against obstructive sleep apnea or prolonged obstructions of the airway. But also, although a child may not have oxygen deprivation, it's very unrestorative. It's very disturbed sleep. So the symptoms can be quite similar, even though it's a compensation. Just open mouth breathing. We want to make sure that children have their mouth closed. And if we have mentalis strain or the dimpling in the chin, that could be an indication that a child is predominantly mouth breathing. It's not easy for them to seal their lips, even though their lips are closed. I've got the FARA 6 here, the top 6 red flags that have been identified by Audrey Yoon and team. Really mouth breathing. We want to make sure that we pay attention to that. The mentalis strain, the tonsils, it's really easy to look inside the mouth, and if they're quite bulky, that could be a problem. The tongue tie, the wear, as you said, and the narrow palate or lack of spacing. They're probably the really easy things for people to look at.
Okay, that's really great. That's good to know. And it kind of keeps it simple, but gives us that awareness of what might be signs of dysfunction. So how do you approach a parent when you discover that a child has such issues?
Yeah, when we discover that child has those issues. I mean, a lot of people come to me, they already have that concern.
Okay.
And that's why they're coming to me. But if it is, for instance, our oral health therapist is seeing a patient, a general child examination, I usually try to go from the dental perspective, like really if there's a lack of spacing or if there's a crossbite, trying to plant the seed that this could be an indication of a bigger problem. And then they can do some screening questions to see is there any snoring, mouth breathing, disturbance, restless sleep, those type of things. So I think just bringing up that conversation, and then she can just refer them to our website or social media, just to help them. Because if they're not coming in for that particular problem, it is a bit overwhelming to give them all this information. But just to be able to at least have that conversation, plant that seed, and get them connected to more information. I think that's how we would.
Okay, I'm just thinking actually probably the majority of patients you see, because you're so well known and you're so specialized, they're coming to you because they already have these concerns. So you can help validate them and get them on the road to treatment. It's probably less common that you have a parent who has no idea.
Actually, Nicole, the reason why I wrote the book in the first place is when I was in general dentistry. When I was in general dentistry and we're seeing children, and then you can see all these problems and not know how to convey them to parents. And so I thought I have to be able to connect all the dots, so it's not so overwhelming. Parents can have something and they can understand why we were doing things a certain way, why it does not make sense anymore to refer to an orthodontist and watchfully wait and take out teeth, why we might approach something different for the next child. I needed to be able to make it simple and easy to understand, and that's why I wrote the book. But because the book took me so long, it took me like 6 years to finish. In that time, I didn't have to deal with that problem, because now I'm just doing consults for people that actually have the problem. I'm not doing the general dental examinations. So now I hope that the book can be helpful for other practitioners who were in my boat before, where you find something and you want to help them understand, here's something that you can take to connect the dots.
And as you know, your book is so amazingly helpful for so many people around the world. Everybody, Breathe, Sleep, Thrive. I'm holding the book up here, and I see photos people on social media are posting, they're reading this book or they've read it from all over the world, not just practitioners, but parents alike. It's such a great resource. And I think it's so wonderful that you put that together. 6 years, it's such a long time to devote to really get that information out there. And it's a wonderful resource. So thank you for spending all that time to really put the research together, the information. There's photographs, there's, guides to really help parents. And it probably does make your job and everybody's job easier, because you can refer someone to that versus repeating the same thing. How do you treat structural growth deficiencies in young children?
Through palate expansion. I'm not shy about offering it. So, palate expansion or widening the upper jaw, it can be done with lots of different designs and appliances. And it's much easier in younger children before that suture is fused. But my preferred option is the BioBlock removable palate expander. So the BioBlock, it's an acrylic appliance that's worn in the mouth 24/7. And at the front of it, there's like these cat wires, which as we're expanding, these wires, they kind of actually control the front teeth and can help develop the upper arch as well, the front of the arch, which can be really helpful for getting a V-shaped arch more round and U-shaped. Or if we have lack of baby spaces between the baby teeth, we can actually create some gaps. If there's a little bit of a crossbite or a little bit of slight malalignment, we can actually really control that. So I love the fact that this appliance can do so much and create some really beautiful smiles and facial changes, because a lot of people don't recognize that palate expansion, it doesn't actually create more room for the teeth necessarily when we widen the jaw. The way that we create more room for the teeth is actually by broadening that arch form, taking that triangle V-shaped arch into a rounder arch, or developing that front part of the arch, which not necessarily all expanders can do, or may sometimes need braces. So what I do doesn't mean a child's not going to need braces, but I have a lot of control over what I do. And that's why, having tried various different expander devices, this is my preferred option. It may not suit everybody, or I have various steps involved to make sure that a child's going to be more compliant. But I can't see everybody. And if I can't see them, they may have to go elsewhere to get a fixed option or something. Yeah.
Okay. And can you explain further what you mean by widening the jaw? It's not expansion that allows more space for the teeth, but it's widening the arch. Taking the V to a U shape is what allows more space for the teeth versus expanding at the suture.
Yes.
Is that what you mean?
That's right. Yeah, because to get more space for the teeth, we need to get more circumference around the arch. Yeah, I mean, if people are listening on audio, it might be hard to see what I'm doing, but we need that big U shape, not the pointy V shape. So the space for the teeth actually comes from that anterior arch development, not from the widening.
Okay. So not just if you do transverse expansion, is that allowing more space for the teeth, or you also need to
Not necessarily. It's widening the arch, and we're getting bony expansion, which is really great for the nasal passages. Like when we get that bony expansion, we're actually remodeling the nasal floor, and it can actually improve nasal airway and decrease nasal resistance, so making nasal airflow easier. But it doesn't really create room for the teeth, extra room for the teeth, because a lot of people think expansion can help minimize extractions and that. But really, if we really want to create more room for the teeth, we've got to get more broad U-shaped arches, not just wide arches.
So how does that
I
work?
hope that makes sense for people that are listening and not following the hand gestures. But
yeah, you're making a round versus a V, but no, it makes perfect sense. Even just listening, it makes sense. So I'm wondering, like with rapid palatal expansion, is that allowing more room for the teeth, or do they also need to do something on the anterior teeth as well?
Yeah, I mean, yes, usually if you're just doing an expander, like a screwed in, a cemented in expander, and it's got a screw mechanism, it's actually just widening the arch. It's just separating the suture, getting new bone to form in the mid palate, but often not necessarily making more room for the teeth.
Okay. So with the BioBlock,
well, for instance, I learned from Dr. Derek Mahoney. He was one of my first orthodontic teachers. He uses a lot of fixed expanders in his practice. It just works well. They don't have to worry about child compliance. So if he does expansion and he wants to correct the teeth positions, he uses like 2x4 brackets. So he'll put like brackets on the front 4 anterior teeth and a couple at the back teeth, and he will actually use a wire to actually improve the arch form in combination with the expander.
Oh, interesting.
So I've tried that before, and I just actually prefer the BioBlock because I don't need to cement stuff, and it's actually quite simple. I have a lot of control over it.
Well, this is a really good point is there's multiple ways to get similar
Yes.
results. There's different techniques. Like I talked to another orthodontist who does like an arch wire expansion, just using brackets without an expander. There's different techniques that people have with similar goals.
Yes, definitely.
What is the youngest age that you would start doing expansion on?
I've done expansions on multiple 3.5-year-olds. So really, it can be done any age as long as the child has all their baby teeth. Like from age 2, I know a couple of providers that offer that, but 3.5 was my comfort zone. But in fact, now, just to make it more simple, I don't do expansion until age 4. So basically, because we're quite busy, I found that I can make the most impact by not taking on children younger than 4, because a lot of the time when they are younger than 4, they may not be quite ready. And so I would refer these patients to other colleagues who can do the myofunctional therapy and kind of work the patients up to be more ready for palate expansion.
And how do you help the children become compliant to use the appliance for it's 24/7?
Yeah.
How do you help with that?
So there's two main things that can go wrong. Number one, I want to make sure that a child is going to be comfortable chewing and swallowing with it. So, probably even more so in the last year, I've really actually, before I start treatment, I want them to do 10 minutes of Myo Munchie. So have their lips sealed, be able to chew and swallow with their mouth closed, because I think that actually promotes, better muscle function. And if a child can do that with a Myo Munchie, which is quite bulky, I know that they're going to transition well to the expander. They're going to have minimal problems with gagging, and they're just going to know how to use their mouth properly. So that'll be easy. So that's one aspect. And the second aspect is the other big problem that can occur with expanders is children that actually use their tongue and they're flicking it out with their, taking the wire out with their tongue. So they're flicking it.
Yeah.
And even though the plates are super secure, the clasps are really tight, they can manage to dislodge it inside their mouth, and then they bite it back in when it's not quite fully seated properly. And then the clip bends and it distorts, and then the plate becomes loose. So, once I started doing quite a lot, then I'm like, oh, okay, now there's like more people coming with these loose plates. And then I worked out, okay, this is what's happening. They're distorting the clasps. So how do we overcome that? I want to make sure that they can actually know where their tongue is supposed to sit on that N spot. Yeah. And so if they use myo spots a couple of times a day, they're really actually getting some awareness of where their tongue should be sitting. And every time they melt them, they're strengthening their tongue, because a lot of kids, they come in and they're like, they're flicking their tongue forward. They don't know how to put their tongue up. So we're kind of training that tongue position and the tongue elevation strength. And I almost want them to, when they come in before they have scans, I want them to be able to lift their tongue tip, make it a pointed tip tongue, and put it on the end spot and hold that there for 20 seconds without thrusting, without extending their head back, or, without using their jaw or other muscles. That's when I kind of know, okay, they know where this spot is. So I can actually encourage them, either flicking their plate, to actually put their tongue on the right spot. But the truth is that when kids get good at putting their tongue on the spot, these are the children that are more still. They're closing their mouth more. They're still. They're not playing with their tongue and moving it all around the mouth. So these are the kids that will not play with my expander as well.
Yeah.
So, yeah.
And is the expander, is it acrylic that's covering the whole palette?
No, it's actually very minimal coverage compared to some of the other swords or the 3D swords. It actually is just like a band that's in the middle, and then most of the palette, anterior palette, is not covered. So for instance, you can put your tongue up and there's just no plastic in that front part.
Okay, interesting. Yeah. We have, in our office, for patients who have the Holly retainer, which is that, wire in the front with the acrylic along the roof of the mouth. Yeah. We have their orthodontist put a little target hole or a notch at that end spot, or at that incisive frame and area, so that it helps them know where their tongue should rest. And then we work on chewing and swallowing correctly, swallowing saliva with that retainer in, so they kind of get that correct feel. Because I can definitely see patients, wanting to flick that retainer or that expander in and out,
Mhm.
which is a sign, obviously, that the tongue's not resting in the correct position.
Mhm.
So that's where,
Mhm.
combined with myofunctional therapy, and you
Mhm.
talked about some techniques, can really make that treatment even more successful.
Mhm.
And we love the 𝐃𝐈𝐒𝐂𝐋𝐀 also. That's a great tool or a great exerciser
Yeah.
as well.
Yeah, and because we see so many people that fly in and out, it's such a big responsibility. You don't want them to have emergencies. So
Yeah.
I've just worked out that I really need to spend that time up front to make sure they get this right. But at the same time, what we've noticed is if a child can do the 10 minutes munchie before they even start the treatment, we can actually progress faster through therapy and habit correction and get them out of the plates quicker as well. So there's a lot of benefit.
Wow. And I think I know there's some people talking about doing research studies with 𝐃𝐈𝐒𝐂𝐋𝐀 and expanders versus 𝐃𝐈𝐒𝐂𝐋𝐀 alone. I think Kevin Boyd and other people are doing some sort of study with that. So do you have your patients get the 𝐃𝐈𝐒𝐂𝐋𝐀 before they begin the treatment with you, maybe before they come to see you, but they're going to be a patient?
Yeah, I try to get it in the first consult.
That's
While
great.
your child is here, we'll take your photos and our team can actually introduce it to them and set an appropriate first goal, if possible. Yeah,
That's so great. That sounds like
yeah,
a really important, helpful step.
yeah.
So as we sort of wrap up, what are some of your favorite or most influential research studies? And you have a million. I learned so much, like I said in the beginning, from all the studies you post. Are there any ones that you kind of like really stick out as being some of your favorites?
Well, I guess, anything from Dr. Christian Guilleminault, he really was a big influence on me.
Yeah.
And around that sort of 2015 to 16, 17 mark, I think that's when he did a lot of papers really promoting oral dysfunction. We need to pay more attention to oral dysfunction. So anything that he does. But if I had to say one particular paper, the one that really resonates the most with me is 310 consecutive patients with rapid maxillary expansion and the impact on nasal breathing. So this was published in the 1970s in an international ENT journal, where they actually examined 310 consecutive patients, and they had palate expansion. So some were 4, maybe the maximum was 18, and they were doing it not because there was a crossbite or a dental issue. These were patients referred for medical indications. So things like recurrent ear infections, nasal prior to septoplasty, allergic rhinitis, and these symptoms, or asthma. So non-related to the teeth. And then they actually reported what they were finding. And there was a high, 90% plus that could actually convert to nasal respiration, and a huge improvement in allergy symptoms. In fact, some of the children that didn't get the good nasal breathing, it was because of really severe allergies. But for a lot of children that had allergies, it actually improved the allergic symptoms like itchiness and, all those type of things as well. And what they were finding was that, yes, it could improve their concentration, their appetites, their speech, and all the various different aspects or functional aspects. And so that's huge to get 310 consecutive patients. And what I found out from Dr. Stanley Liu is, like, when Dr. Christian Guilleminault passed away, he found this paper that Dr. Christian Guilleminault had found and been keeping. And it was part of his whole thinking and why he was exploring palate expansion. So it's very foundational. What all of us do now, this paper is a really important paper. But what's really interesting is this paper actually comes from Perth, which is where I live. And so a few years ago, I decided I was going to seek out the orthodontist who was aged 92 at the time. And I chat with him to find out more about this paper. And he actually said that they had expanded 2,000 children at that time. And it was largely by medical referral. Like, none of the orthodontists, they didn't want to know about it. They thought it was maverick. When the ENT passed away, they actually stopped doing it. So the orthodontist wasn't able to continue. But it's so impactful. It was done here in Perth. We have maybe some of the most resistance from the orthodontic community in this area. Some of the vocal ones that do the editorials in the orthodontic journals, but yet this research was done here. And what this tells me really is that we cannot overlook the key role that palate expansion can play to help restore nasal breathing.
That's amazing. And you connected with one of the authors from that study, and he was 94 years old.
92. He was actually not the author. The ENT was the author, Dr. Lindsay Gray, but he acknowledged the orthodontist. So even then, my husband said, "Oh, I think I did a talk like about 10 years ago, and Perth's first pediatric dentist was in the audience, and I talked about that talk, and he said, "Oh, that brings me back to the time when I was a registrar, and I was actually removing all the expanders." And my husband said, "Oh, Shereen, there's got to be other people that know more about this study. Why don't you seek them out?" And that's why I decided to seek out the orthodontist, and I'm really glad that I did.
How cool. You would do that. That is so cool. I love that.
Yeah, to think they did 2,000 children, like,
Yeah. And that
in the
long ago.
70s.
A lot of this comes back. A lot of things we're doing now or talk about now are not new concepts.
Mm-hmm.
You go to these conferences and people are showing articles, like especially Kevin Boyd, and articles from years ago, early 1900s, and it's not new. Myofunctional therapy is not new. Early 1900s, myofunctional therapy became, and some of these concepts just get, they come back again, or they regain popularity, or we realize, oh, we were onto something, and for some reason it was shunned or pushed aside. So if you had any advice for dentists, orthodontists, and patients and families, what advice would you give? Maybe each kind of category separate.
Okay, so we'll start with the orthodontist.
Sure.
Okay, I think with the orthodontist, I would really encourage them to go out and do one of these Airway courses, because I think it's one of those things, once you see it, it's really hard to unsee it. But the trouble is just getting out of your comfort zone to go to one of these courses. It's so different and foreign, and they hear, oh, a lot of this is about making money, it's not ethical. But I think when you go to these courses, it's really hard to not see it. And you can understand that it's not really just about the teeth. It's actually so many functional improvements to be had, and being able to impact a person's trajectory of breathing and sleep. So that's what I would say for the orthodontist, to actually go out and just keep an open mind and listen to one of these conferences. The general dentist, I think, being able to offer a screening for every single patient, because, many of the risk factors can be, like, there's so many key risk factors that can be seen inside the mouth. Even just learning about the Ferris 6 screening tool and understanding why these are the red flags and what to look for, and how to do a really quick screening. I think Dr. Jeff Rouse is really one of the best people. He's got some content on Spear Online. He always tries to make things very practical so that we can incorporate it into our practice with very minimal time. And in terms of parents, what do I want them to understand? Just really understanding that we need to see children, their sleep should be peaceful, relaxed, quiet. They should look more still. And to understand that really nasal breathing is super key for optimal health and development. And when we look at nasal breathing, let's not ignore the contribution of poor structural development of the palate. And I think just in general, with all of healthcare, really paying closer attention to airway health. Really, it is the cornerstone of thriving vitality and well-being. And if we can pay attention to that rather than react so much when we have problems and diseases and medicating and surgery, we can really change the trajectory of many people's lives. Yeah.
Well said. That was amazing. I really want everyone to make sure they get your book. And this is just a little summary of your book. Breathe, Sleep, Thrive, Understand Airway Health to Unlock Your Child's Full Potential. Did you know the way a child breathes will impact every aspect of their development, including their sleep quality, learning, behavior, jaw and facial development, speech, and future health? Common issues children experience, such as snoring, poor attention and concentration, ADHD symptoms, difficulties with emotional regulation, recurrent ear infections, speech or feeding concerns, teeth grinding, crooked teeth, and more can often be symptoms of a bigger underlying problem. These can all be symptoms of dysfunctional breathing and unrestorative sleep. The book is about how a child's breathing can affect their development in many ways, including their sleep, learning, behavior, and speech. And it also discusses how common issues like snoring and poor attention can be symptoms of a bigger problem. And this book was published in August 2022, and it will help guide all practitioners and parents and families alike. So, Dr. Shereen Lim, thank you so much for your time. I know you are just at the start of a long day helping children and families, and I really appreciate everything you do for the community. You're just amazing.
Thank you. I believe the same as you. Genuinely, I love your passion and what you do and appreciate the opportunity, Nicole. Thank you so much.
Thank you. Have a great rest of your day.
Okay.
Take care.
Take care. Thank you.
Bye. Thank you so much for joining this episode of Airway Answers. I'm hoping some of your Airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.